Good morning. Today we're talking about GI Part 2 and mostly your kidneys. Here's your objectives. So, you guys already know what the kidneys do. You've already been through patho. So, let's talk about the physical assessment. First things first, we're going to be asking questions. Are they on different medications? Are they on antibiotics? Seizure medications? These type of medications are incredibly hard on the kidneys, and we want to make sure we know what the patient is taking. Have they had a lot of exposure to any type of toxins? Have they had a CT scan or anything where they've had IV contrast lately? We're going to be watching for urinary changes themselves, so color, odor, volume, what their intake output looks like, and any type of over-the-counter medications they could be taking. Your diagnostic exams, you have your creatinine, your BUN. Remember, creatinine is the best indicator of your kidney function at that moment in time. Urinalysis is going to check for bacteria, blood, white blood cells. CT MRI is going to be looking at the physical system itself. The ultrasound, the patient does need to have a pretty full bladder. So we want to make sure that they are drinking water before we do that ultrasound, or we won't be able to see anything. Cystoscopy. This is where we go up into the bladder. So if we're going to get bladder samples, we do a cystoscopy. We also can put urinary stents in during a cystoscopy. But a renal biopsy is kidney tissue. So for a cystoscopy, you cannot get kidney tissue. You have to do a renal biopsy. So we're going to be watching the puncture site on the flank. Make sure there's no hematoma forming. Make sure there's no internal bleeding that we have to immediately report to the doctor. Let's talk about kidney disease. First one up, acute kidney injury. This is acute. Something just happened. There was a trauma, an MVA. They fell off a ladder and hit their back. Something just happened, okay? This is reversible. This is reversible. Severity is based off what the BUN and the creatinine look like and how the urinary output is going. If the BUN and creatinine are only a little elevated and there's adequate urine output, this is mild and the body probably can fix it itself. Once it gets more severe, or if it is more severe, we're going to be looking for metabolic acidosis. We're going to be looking for hyperkalemia. If we're concerned about hyperkalemia or we want to know, you throw the patient on tele, and that is going to tell you if the patient is stable. How fast do we need to move? If the patient is unstable and they're having dysrhythmias and their potassium level is high, very often the patient's going to be put on Kayexalate to get that potassium out of the body, okay? Different types of AKI. You have your pre-renal. This is perfusion issue prior to the kidneys. I'm sorry, yeah. Blood loss, hypervolemic shock, hypotension, anything with the heart or liver failure, okay? That's pre-renal. Intrarenal, this is actually damage to the kidney tissue. Inside the kidneys, bleeding, trauma, clots. Watch for individuals that have lupus. Lupus will very readily attack the kidneys. So that's why we're watching for any nephrotoxic signs and symptoms if someone has lupus. And then post-renal, this is obstruction of the flow of urine. Maybe they have bladder cancer. Maybe they have an enlarged prostate. Maybe they have kidney stones, things that are blocking the flow. Different phases that we're going to be watching for. The onset, we're going to be watching the urine output. You're also going to be watching for the increase in BUN and creatinine because that's our measurement tool. We're going to see how severe this is, severe the injury is by that BUN and creatinine and by their urinary output. Watch those electrolytes. That's why we like to put them on telemetry. Then you have Oberia phase, where it's minimal urine output in a 24-hour period. And again, we're watching that potassium level. And then diaphoresis is when the kidneys start to recover. You're going to see the BUN and creatinine go back down. You're going to see the potassium go down if it was raised, and you're going to see the urine output have a tick up. We are going to be watching them closely though, because in diaphoresis stage, they can overproduce urine kind of as a default. So we're going to make sure that they're not getting dehydrated. And the recovery phase can take up to 12 months, but it can also only take a couple months. It just really depends on what is going on and the severity of it happening. Different treatments. So we're going to monitor labs, which we've talked about, what medications are on, if any of the medications can be weaned off, if any of the medications can be changed that could be affecting the kidneys. We're going to be watching their daily weights, make sure they're not gaining a whole bunch of weight that we might not be able to see if the body is compensating right away. Nutrition therapy. We actually want them to avoid potassium, phosphorus, and protein foods. Lower the sodium intake and control their PO fluids to the point where we might actually have them writing down what oral fluids they're intaking, so we have a measurement for that. Some of the medication treatments that you could see, the dextrose or insulin, or like I said, the Kayexalate can lower the potassium level. Procrit, Edrin, this raises RBCs, but if the RBCs are within normal range or they're close to normal range, let the physician know because he may not want the patient getting that Procrit. Folic acid and iron, just to help back everything up. Diuretics, we use this to improve filtration. Even if the kidneys are hurt, they're still filtering, so diuretics can help them out. And then the medications to lower potassium. Last resort, there's something called continuous dialysis, and we'll talk about that in a little bit. And if it gets to the point where it's very severe, they could go on hemodialysis, which we'll talk about in a little bit. So here's an overview slide for you to peruse. Chronic kidney disease. All right, so now we're in where the kidneys need constant backup, either throughout the day or 3 days a week, okay? This is progressive. It is irreversible. The kidney function doesn't recover. So you can have somebody that has acute kidney injury that was not treated correctly. Maybe the patient didn't even really know what was going on, and it can be pushed into chronic kidney disease. It usually needs to be having lab results greater than 6 months to a year from knowledge base. So we do need those labs to prove it. We can also go off of assessments. Again, we're still looking at acid-base issues. Good part is chronic kidney disease is typically slow moving. We have a higher risk for it if you have diabetes, uncontrolled diabetes. And if we're concerned about the patient's assessment, we're looking at LOC. We're looking at cardiovascular. Again, what's that potassium level? How is the body reacting to this disease process? Do they have edema? Do they have pulmonary edema? Do they have crackles? Do they have bounding pulses? Do they have JVD? What is going on when you look at the patient? Are they anemic? Is their H&H low? Or is it getting washed out? They could have ulcers. Anorexia, they have that not because of a mental health issue, but if they're so backed up with fluid, the patient's not going to want to eat, which is going to be even harder to get the chronic kidney disease under control. And then look at their skin. Is it dry? Is it flaky? Is it itching? Is there like that frost over it? That is Emmerich frost. And do they have a decreased skin turgor? Are they dehydrated? The different stages of chronic kidney disease are here for you to read. These have not changed since you started MedSurg 1. So let's talk about diagnostic tests with chronic kidney disease, okay? There we go. Potassium again. If the kidneys can't filter out the potassium, they're going to be at a risk for heart issues. They could be anemic, so we're going to be watching for that H&H. Once again, if the physician has something like Procrit ordered for H&H, if it's higher, the H&H is either within normal limits or right about there. Let the doc know. They may not want to give it, may not do any good. Nursing care, what's our role in this? We're going to be watching the patient's daily weight, around the same time of the day, the same scale. It's important to teach the UAPs why that's important. It's going to give us the most accurate information. When they go home, the same thing. They should weigh themselves around the same time every day on the same scale. Okay. We'll be watching anything with high protein, phosphorus, and potassium in it. Also going to be on a fluid and sodium restriction. These are individuals that are going to be on dialysis, and we actually want them to monitor their fluid intake. So when they go get dialysis, like hemodialysis, the nurse understands how much they took in for the last 48 hours, so they know how much they should be removing. Respiratory assessment, we're going to monitor for fluid access. Are they crackling? Do they have shortness of breath? Is their pulse ox dropping? If we're going to do hemodialysis, typically we hold all the meds beforehand because the hemodialysis is just going to filter them out. So there's really no point of giving them. Doesn't do any good. Medications. We talked about Kalaxlate, which it lowers the potassium. Epigen is an RBC booster that can be given on the days of dialysis days. We're going to monitor the H&H for that, though. The calcium carbonate, even though it says calcium in it, we're going to be checking for those phosphate levels. So calcium carbonate is something they typically take 3 to 4 times a day, and it's a phosphorus binder. So we do have them take it with food or right after they have eaten. So the different types of dialysis. We learned about 2 in MedSurg. 1, hemodialysis and peritoneal dialysis. And now we are going to add the 3rd one, which is a continuous dialysis, continuous renal replacement therapy. So those are the 3 we're going to talk about. So hemodialysis. This is where the patient is in usually a stage 4 to 5 end stage kidney failure, where the potassium level is not managed well at home. They're in constant fluid overload. They typically go 3 times a week. And this is something where they have to go to the hospital or go to the dialysis clinic to have completed. They also are going to need either a large bore subclavicle line put in, but long term, we're looking more of like an AV fistula or permacath. Remember, anytime there's a surgery, we go distal to look for circulation. So if you have somebody that has an AV fistula put in the arm, we're going to be looking at the radial pulse. We're going to be looking at circulation at the tips of the fingers. So we're going to be looking for capillary refill. For hemodialysis, we do want the patient measuring their input so they can report off what they had before the dialysis, so we're not taking too much off. If they're using heparin as part of the anticoagulation protocol, or maybe they had surgery and they're just on a low dose of heparin, just be watching the AV fistula or the permacath or whatever they have in for bleeding. It might be just a little bit of extra oozing that we have to take care of, but if it's progressively bleeding, we're going to have to let the physician know. So for hemodialysis, we are going to hold medications because the dialysis machine is just going to dialyze most of them out. For somebody that has a fistula in the arm, we don't do blood pressures, we don't do blood draws, we don't put IVs in there, and we don't want them wearing anything overly tight that could suppress the flow inside of the fistula. Albumin is a common order that you'll see put in because of all of the toxins we're pulling out and the body's not producing the albumin it should be. So you could see albumin being ordered to be put in with the hemodialysis. We're going to be watching for signs of severe fluid volume deficit. So all of a sudden their blood pressure goes down, their heart rate goes up, they get dizzy, they get fatigued, they're passing out on you. It could be a sign that we pulled off too much fluid or we're pulling it off too fast. If that's the case, we want to put the patient's head down, not necessarily supine. I'm sorry, supine or even Trendelenburg where the head's down. The head's below the feet. And we might give small IV boluses if we need to, or we might go ahead and do a presser to help get that blood pressure back up. Now we're on to peritoneal dialysis. This is very typically done at home. So we do want to be talking to the patient about sterile technique, clean technique at home. So we do want to make sure that peritoneal catheter itself stays dry and clean. If the fluid coming off is cloudy, they need to call the doctor because that does indicate an infection. They should be maintaining clean technique when they're dealing with the bags and sterile technique when they're hooking the bags to the catheter. And they should increase protein in their diet. So very purposely increasing the servings of protein that they're taking in every day. This does not include, by the way, most protein powders. Most protein powders are actually very hard on the kidneys. So we just want them to eat foods higher in protein. When we're doing peritoneal dialysis at the hospital, which we could do, there's some steps that we're going to take to make sure that we are following the policy. So the first thing we do is check your orders, any labs, any vital signs, okay? I want to make sure we have a baseline for everything. We are going to warm the fluids up because we do want to get them up to body temperature. Remember, a normal room in the hospital is going to be between 65 and 70 degrees. Your body temperature is roughly 98. So we do want to warm those fluids up a little bit because you could send the patient into a little bit of shock with those very cold fluids. We're going to maintain the sterile technique while you're hooking up the fluids to the catheter. Same kind of thing we're going to teach the patient at home. And then during it, we're going to be watching for abdominal pain, cramping, bloating, respiratory issues. We're going to be listening to their lung sounds for crackles. Are they breathing well? Is there any signs of fluid volume overload? And then once we're done, we're going to look at the fluids that came out. Make sure nothing's cloudy. Make sure there's no odor to it that we have to notify the physician about. Complications. If the catheter is loosened at all, there could be a little bit of standing fluid in the abdomen, which can cause some issues. Sometimes the body will reabsorb it, but it can cause infection. The catheter site itself that we're looking, make sure nothing's red, swelling, there's no drainage, and basically the signs and symptoms of infection. Looking for protein loss. Again, we want to encourage them to have increased protein at home. We're going to be watching glucose levels because it could spike because there's dextrose in the peritoneal dialysis fluid. And then pore flow. We want to make sure that all the tubing is flowing, that the catheter is flowing, make sure nothing's backing up into the patient. So it's your daily checks here and some diagrams of peritoneal dialysis. All right, and the last one that we're going to talk about is the continuous venous hemofilter, so CVH. This is not something we talked about at MedSurg 1, so this is a new concept, okay? This is a continuous dialysis, and you'll see this a lot when you have a patient that's hemodynamically unstable, typically from a trauma. So they're an acute kidney injury, okay? I've had patients in horrible car accidents where they're vented. We have them on continuous renal replacement therapy, and they've even had balloon pumps in after surgery. So we're constantly monitoring their input and output when we're doing this. A lot of times they are intubated, but they can be awake and they can know exactly what's going on, okay? Couple things that are different about this aspect is we're going to be doing constant frequent labs. Their electrolyte levels can be erratic. They can go up and down pretty fast. We're also going to be watching their heart rate and their blood pressure because their circulatory system is going to be under attack while we do this. Once they're more stable, they can go to more of a 3 days a week thing for a hemodialysis or even peritoneal dialysis, depending on what's going on. And then we go to kidney transplant. So kidney transplants you can get from a live donor or a deceased donor. Once we do a kidney transplant, we do leave the old kidneys in and graft in the new one. This patient is going to have a lot of education aspects going on in the hospital, and then even after they leave the hospital, there's going to be quite a list of education, okay? So pain management, coughing, deep breathing, all the normal stuff that goes along with having surgery, okay? Some very specific things about kidney transplants though, okay? We're going to be doing assessments of fluids and electrolytes, kind of like what goes in must come out. We're going to be doing fluid bolus challenges on these patients, where the physician is going to order a certain amount of milliliters, 250 milliliters, 500 milliliters, and we're going to empty the Foley catheter. We're going to give the bolus, and we're going to see how much comes out from the bolus. Basically, we're seeing how well the new kidneys are working, or the new kidney is working, excuse me. The new kidney can actually overwork too. So the new kidney, we're going to be watching electrolytes because what could happen is they could do their job a little too effectively, and all of a sudden you'll see electrolytes drop, okay? There's not much we can do about this. We'll just replace the electrolytes, and the kidneys will slow down in their cleaning, okay? They will slow down. We're going to be watching for any types of infection and rejection. So when we talk about rejection, when it comes to labs, we're looking at the BUN and creatinine first. If they start to go back up, there might be a rejection aspect going on. Ischemia can happen if there's a delay in the transplant. That's why there's typically an hour base. I cannot 100% remember, but I believe kidneys are 6 hours from removing the live donor or the cadaver donor into a new patient. I believe we have 6 hours to get it in. Or there could be an ischemic issue going on. We're going to be watching for any type of hypertension, any type of bruise over the artery, a low urine output, elevated BUN and creatinine. These are all signs that there is a rejection aspect going on. All right, and the questions are here for you, and the answers are in the notes of the question. Hope you guys all have a good day.